running out of battery. We're going to divide this into 4 segments, and I will skip a lot of this to just show you mostly the images. So first is finding the findings, and this is a sentence from Rolf Walter Emerson that we use in the Fetus Net, which is, people only see what they prefer to see. And this is very true. If you don't know what you're going to be looking at on the image, it is very easy to miss the findings. So here's a case, and I'm going to show you 5 images. And I want you to tell yourself what is abnormal on these images. The first 2 images and the next 3 images. Okay? Okay, here. So we have a soft tissue mass in front of the abdomen, and the most likely diagnosis here is omphalocele. However, could it be gastroschisis? No, because gastroschisis would have irregular edges. Now, what is this thing here? A bone. So, any of you has seen omphalocele with bones? Look at that here. Any omphalocele with bones? And here this looks like a cross-section for leg. So now we have an omphalocele that has legs. Anyone seen that? No. This is what this baby has. This is the baby, and this is what it has. You see? So what is that? A conjoined twin, a teratoma, or epigastrius? Epigastrius. This is what it is. This is the epigastrius, or heteroparasitic twin. This is an example from Ambroise Paré. You see the head attached to the other person. This is one from India, which is almost the same. This is a little boy that has a brother attached to himself. This one had arms, ours did not have arms. And this one is from Bartholinius, you know, the guy from the gland. And this is the opposite. Here we have the head, but no limbs. And then this is one which I think is very interesting. This is a French one. She was called the four-legged lady, and she was born in 1869. And just we have seen in the previous lecture, in 1869 there was no medicine, there was almost nothing. In particular, there were no proteins, protein had not been recognized, and hormones had not been recognized. And the doctor who looked at this person found that the legs were peeing independently from the host, but they were menstruating at the same time. So he postulated that there was a central regulation for menstruation and a local mechanical regulation for urination. I think this was a very interesting example of a birth defect that helps solve some issue of physiology. So the teaching point here is do not jump to conclusion when diagnosing something familiar, because otherwise you have to explain the extra finding instead of putting the findings directly into the image. Another case here. Here we have 5 babies that have a full stomach. So what's the diagnosis? Duodenal treatment. Okay. So if you think duodenal treatment, you are 20% correct. This one baby here has duodenal treatment. Now, how about this one here? Why is this not duodenal treatment? You see the double bubble, you see the polyhydramnios. Why is this not duodenal treatment? Compare this one to this one. Look how big the stomach here, big the duodenum is. This is a condition called a combined duodenal and esophageal atresia. So nothing can enter the stomach, nothing can exit the stomach. What's inside the stomach? Gastric secretion, hepatic secretion. Okay? So this baby gets very large stomach, much bigger than in duodenal atresia, because in duodenal atresia, if the baby drinks too much, he will vomit. Just like when you have baby, you have to birth them, otherwise they're going to vomit. Same thing happened in duodenal atresia, which is the reason you see the esophagus of this baby better than other babies. So this is combined duodenal esophageal atresia. How about this one here? Why is this not duodenal atresia? What is missing in that baby? How about the emetic fluid? Can you have dural atresia without polyhydramnios? Yes or no? No. The only time you get dural atresia with no polyhydramnios is when the mother just ruptured her membranes. And then she will tell you, I was doing some shopping and I ruptured my membranes. So this is something. This here is called dural stenosis. This is an obstruction of the duodenum, but it's not a complete obstruction, so that fluid can pass. This is a different thing. Here, this is pyloric web. This is a peristaltic wave going through the stomach. Now, this baby here has something very interesting. It looks exactly like dural atresia. It's almost the same thing, but it's a different etiology. This baby has an annular pancreas. So if you remember in embryology, you have a ventral end-log and a dorsal end-log, and they rotate so that they merge together. If they rotate the other direction, then the ventral end-log is going to squeeze the duodenum, and you get this image over here. This is an annular pancreas. Now, interestingly, dural atresia, combined dural atresia, and annular pancreas are all three associated with trisomy 21. Okay? So, although it's tempting to jump to the first and the statistically most common diagnosis, this is called shooting from the hip in movies. Cowboys, they don't aim, they just shoot, and then they look forward afterwards. We have a president in the United States that does that right now too. So in prenatal diagnosis, it's better to search for additional clues and then include differential diagnosis. Now I'm going to show you a case here that has short limbs. And I want you to see what else than the short limbs is present. So look at the elbow of this baby, and the elbow has a particularity here. You see that little horn here? And then I'm going to show you the knee of the baby. You see the knee also has a point at the end of the knee. And then I'm going to show you the ribs of the baby, and the ribs have something particular. Look at the ribs. You see the end of the rib? It looks like little forks. Okay. You see the little forks at the end of the ribs? So this baby has several findings. It has macromelia and it has hypomineralization. If you see both ends of the ribs, it means the baby has hypomineralization. Let me show that to you. So when you look at a femur with ultrasound, you're not seeing the femur, you're just seeing the proximal cortical. You don't see the distal cortical, because the proximal cortical absorbs all the ultrasound, and then you have shadowing behind it. So if you see the proximal cortical and the distal cortical, it means that there's not enough calcium in the bone. It's hypomineralized, and so then you can see both corticals. So this baby has short bones and hypomineralization. Now, what do we see at the elbow and what do we see at the knee? Is this a fractured bone that goes through the skin, an exostosis, or a bony spur? Okay, so this is called a bony spur. Now, if you don't know what a bony spur is, you can go in OMIM. How many of you are using OMIM? Raise your hand. Any using OMIM? Okay, 5. Oh, pretty good. About a quarter of you. Good. So if you put bony spurs at OMIM, you have two differential diagnoses. Frontometaphyseal dysplasia. These are babies that have big supraorbital ridges, and that's not what it is. And hyperphosphatasia infantile, and that's the diagnosis. So here, by having the right keyword, you go right to the correct diagnosis. Now the teaching point is, use the least common finding as your first search criteria. If you would be searching for macromelia, there would be many different short diagrams of it. But bony spur is the only one that is fitting here. Now the problem with that is that you have to have the right keyword, because if you put pointy elbow, you will not have any answers. So you have to have the right keyword, and that's the reason for reading as much literature as possible, because that's how you get to memorize all these names. Now, this is an ugly image, and I'm going to skip over it, but there's an anomaly here that I want you to recognize. What's the anomaly in this picture? Where's the spine? The spine is here. This is apex. Which ventricle? Left ventricle. This one? Right ventricle. What is this vessel? This one? This one? And this one? Exactly. Very good. So this is a persistent superior cava, and if you don't know how to look for a persistent superior cava, it's difficult to find. So let's see what is the most significant finding. So when you have multiple findings, you have to do some search, and the best way to search is OMIM. But which one is the most important keyword? So what you do is you find these findings by typing each of the keyword here and finding how many answers you get. So you put one keyword at a time, count the number of return diagnoses, and then combine the keyword that have the least number of diagnoses. Let me show you an example. This is a series of pictures. I'm going to show you 8 pictures. These are the first 4. What is the anomaly of this baby? You can see 4 chamber, outflow tract, 3 vessel view, aorta. So the findings do not include a VSD, a thinking artery, hypoplastic right ventricle, or overriding aorta. Well, we'll see in just a second. Boy or girl? Oh, ambiguous. Ambiguous. Okay? So here we have a VSD. The ballerina foot is broken, overriding aorta. And we have a small pulmonary and a large aorta. So VSD, overriding aorta, tetralogy flow. Okay, so the baby had tetralogy flow, and the mother started crying and said, "Oh, doctor, what's going to happen to my baby?" And you're going to say, "Well, we have some cardiac surgeons here, and they can repair them, and the prognosis is going to be pretty much okay, or the prognosis is not very good." What do you tell her? Tetralogy flow is very common, huh? Most cardiac centers can repair tetralogy flow. So you tend to say, okay, it's pretty much okay. But remember, this baby has ambiguous genitalia. Does a cardiac surgeon care about ambiguous genitalia? Probably not, huh? This is not his part of the body. What is this here? The eyes. What's wrong with the eyes? What is that? Eyelashes, very good. These are long eyelashes. When you scan, you look for eyelashes. You should, you know, when you look for the eyes, you look for the eyelashes. So, is it a big deal to have long eyelashes? Most women like to have long eyelashes, huh? So, not a big deal. Now, one more thing. What do you think about the imaging fluid here? Normal or too bright? Too bright. Too bright because there is some particles or some blood, or because the gain is too high? Yeah, the gain is too high here, and the reason for that is he wanted to show this thing here. Yeah, what is that? Hypertrichosis. These are chest hair. So this baby has hypertrichosis, chest hair, okay? You look for that when you scan, now you look for that. So this baby has the tetralogy flow and because genitalia, long eyelashes, hypertrichosis. Does it make a difference? How do we put this together? Well, we can go into OMIM and we can put tetralogy fellow, and there are 61 articles. That's a lot of time to worry that. So we need to make a shortcut. So let's put tetralogy fellow in neonate, and we have only one article. And this is the someone that has cytopenia, absent syndrome, the TAR syndrome. That's not all what this baby had. So this was wrong direction. We'll try something else. Let's try ambiguous genitalia, 62 article, too much. So what we try now, long eyelashes, 52 article, too many also. Putting neonate, oh now we have only 4 articles. That's something we can read. We can try also hypertrichosis, 67, too many. Hypertrichosis neonate, only 4. So which criteria are you going to be using? Which keyword? Going to be using hypertrichosis and long eyelashes. Only 6 articles, and if you put neonate, now we have only 2 articles. That makes it quite easy. Now, which of this diagnosis is it? Cornelia-de syndrome. And if you click over here, you have a whole description of Cornelia-de syndrome. Now, that's interesting because this is what those babies look like. What's the prognosis for Cornelia-de syndrome? Very poor, very mentally retarded, and so it is unlikely the cardiac surgeon is going to spend time on repairing the tetralogy for a baby that has such a poor outcome. So you see, if we had gone at the beginning and told the mother, oh, the baby has tetralogy, we can repair that, no big deal, well, we would have given her false hope. Now that we have the whole picture, we have a very different story. Now notice those babies have the eyebrows meeting in the middle. You see how they meet in the middle? Like this. Not in the little girl. Why not in the little girl? Because the mother don't like that, so they plug the hair in the middle. This is called a synophris. So the teaching point here is when there are multiple findings, use the most discriminative. To find the most discriminative, look at the number of hits in OMIM, and then combine those that have the fewest number of hits. Here's another difficult case. I want to see how many vessels are in the umbilical cord. This baby has endometriosis, and I want to see how many vessels here. So it looks like 1, it looks like 2, it's not very sure. What do? We put color Doppler. And when we put color Doppler, how many colors do we see here? 1 or 2? 2 colors, a blue one and a red one, okay? So the findings here is this image here, this color Doppler, and this image here. So, is this a double umbilical vein? Yes, no? No, because they'll be the same color. Is this an arteriovenous fistula with blood coming in one way, coming back the other way? Yes, no? It could be, but if it was an arteriovenous fistula, there would be a lot of venous drainage, and we don't see that, so probably not. Aneurysm of the vasa viscerum, that doesn't exist. None of the above. So we have 2 vessels, they go in opposite direction, and this is interesting. Look at this vessel here. It comes from the aorta and it goes straight into the umbilical cord. So here we have a very unusual vessel that got right out of the aorta and goes into the umbilical cord. So this is what is called a replaced umbilical artery to the supramesenteric artery. So normally we have 2 umbilical arteries going this way. This baby is missing one of these 2 umbilical arteries, and his umbilical artery is arising from the supramesenteric artery. So this is a fascinating point of embryology. Birds use the vitelline or inframesenteric arteries, but when we moved from the yolk sac to using the placenta, we completely abandoned that system and we moved to the umbilical arteries. Now, this is a case in which there is a regression to a more primitive phylogenetic stage where the vitelline artery was the source of feeding for the embryo. And so what does this guy use? What is that? That's a platypus. They're from Australia, and they have a beak, and they lay eggs, but they're mammals. And so I tried to find what it was, what kind of vessel they had, but no one knew. Here is a series of video clip, and I want you to know what that big cystic thing is. What is this here? Ovarian cyst, mesenteric cyst, obstructed bladder, or duplicated bowel. So, bladder obstruction. Let me explain that for you. It's a girl, has no amniotic fluid. So we know the cyst is the bladder because we have the umbilical arteries alongside. Any connection that has the umbilical arteries alongside has to be the bladder. There's nothing else again. No mesenteric cyst, no ovarian cyst, no nothing. So it's the bladder. So why do we have an obstructed bladder? We have, this is the list of potential obstruction. Posterior urethral valve, urethrogenesis, major atresia, obstructive uterocele, or the megacystis microcolon hyperhidrosis syndrome. So how do you select from that? Well, I was not very honest. I gave you the diagnosis of obstructed bladder, and that's not correct. And it's not correct because we have seen the amniotic fluid was normal. So it's not an obstructed bladder, it's a distended bladder. You see, amniotic fluid was normal. So if it's not obstructed, if it's just distended, all these diagnoses don't work. It cannot be any of these. We don't see a ureterocele, so that's not possible either. So the only one possible is the megacystis microcolon hyperhidrosis syndrome. So you tell that to the mother, and so can we put a shunt in my baby's bladder? I heard that in Denver they put some shunt in the bladder. Can we put a shunt in the bladder? Who wants to put a shunt? Who doesn't want to put a shunt? Who doesn't know whether to put or not to put? Okay. Well, what's in the name? Obstructed bladder versus distended bladder, or distended bladder versus obstructed. If you ask Julia, what difference does it make for the name? It makes a big difference because you go and do search in the wrong direction. So you have to be precise in the terminology that you're using. So this baby is going to die not from the obstruction of the bladder, she's going to die from the hypoparesis syndrome and the microcolon. So there's no point in continuing pregnancy, there's no point in doing a shunt. This is not going to have this little girl. So I'm going to go very rapidly through database and the web because many of these things are common. I want to show you OMIM here. So this is OMIM, and it stands for Online Millennial Inheritance in Men. And there's some numbers, but you can skip that. So one of the issues with OMIM is that you have a lot of keywords. So if you skip. So if you type short limbs, for instance, you're going to have a lot of diagnoses. And this is, if you add any keyword, it's automatically considered to be N. So short limb and thumb was the same thing. Now, if you show limbs, with just the plural, you have even more diagnoses. Now, that doesn't tell you that these are babies with short limbs. It tells you that these are articles that have short and limbs. So you could have short nasal bone and long limbs. You'll be according to that. So what you need to use is short limbs between quotation mark when you need to have the precise translation. You skip that. Okay. Now, when you do some searching in OMIM, you can find a connection to the right side. You see diastrophic dysplasia, and when I go to the right side, you have gene test. Any one of you has gone on to gene test? So that's an important website, also covered by the NIH. And if you click here, you have a chapter on diastrophic dysplasia, whatever condition it is. And these are very well written articles by very qualified people. And if you look into the table here, you have clinical testing, and you can say, okay, I am from this country, or I'm from this state, and then you can find who's the physician working on the subject closest to you. So you have the email, you have the phone number. So when you're scanning a baby that has something unusual, you can say, okay, what kind of fluid do I have to give this person? Amniotic fluid, whatever, and how many cc, and how long does it take to get the test, how much does it cost, so you can get some very important diagnosis this way. Unfortunately, ob&gyn does not contain images. Now, if you look at the same box here, instead of clicking ob&gyn here, you can get PubMed. And PubMed is just a big database. I'm sure that you all know about that. So I'm going to skip this. The next one I wanted to show you is the one that is dear to my heart. It's the FetusNet. We started this in 1999 on paper, originally in 1991. And now we have actually about 75,000 images, about 1,200 video clips, and now 415 soft cases. There's a lot of material, and you don't have to register, you don't have to pay subscription, no nothing, no sign in. And we get about 5,000 to 7,000 visitors per day from all over the world. And here on the left side we have the case of the week, and on the right side we have the answer to the case of the week. Now we used to have a nicer system in which people could answer, and then we would say, are you sure, do you want to look at this a bit more? Or we would say, good idea, but not correct. And unfortunately, what happened is there was a group of physicians that were cheating. They were sending one person at a time until they had the diagnosis, and then everyone was sending the correct diagnosis. So that's the reason we had to change, but you can still do that. So let me go back to putting it all together. And here, there's a basic level to have good scanning technique and equipment. So is this a good NT scan? Yes, no? No, it's not a good NT scan because it's oblique. So you have to have good scanning technique and good equipment. Then the next thing is you have to recognize normal for abnormal. This is an 18-week exam. The whole exam is normal except for these two images here. And you see there is a small enlargement of the lateral ventricle. And then what's wrong with this picture here? No nasal bone. Okay, no nasal bone and mild, upper limit ventricular memory. How many of you successfully emesentesis? No emesentesis? No one? One person. What's the diagnosis? So this baby has a combined trisomy 21 and Klinefelter. The entire examination was normal except for the nasal bone, and she was African American. So be careful, small findings are important. 2 umbilical cord cysts. Which one is the omphalmocentric cyst and which one is the allantoic cyst? How do you know? Well, go back to embryology. This is an 8-week embryo. You can see the connecting stalk, and in the connecting stalk we have the umbilical artery, umbilical vein. We have also the allantoic duct. The allantoic duct is the roof of the bladder going towards the trophoblast. And then opposed to that, coming from the outside, we have the Vickling duct that connects the yolk sac into the embryo. So now when you have this schematic in mind, it's very easy. If you have an allantoic cyst, it's going to spread the vessels apart. If you have an omphalmocentric cyst, it's going to push the vessel together. This is called a diamond ring appearance. It looks like a ring with all the diamonds on the other side. So when you look at these two images now, it's very simple. This one is the omphalmocentric cyst, and this one is the allantoic cyst. So again, knowledge of anatomy and embryology is very important. And when I was a medical student, I hated both of them. So I now have the biggest, I used to have the biggest library of anatomy and embryology, but I gave it away. And then recognize the findings. So here we have a baby that has ascites and has big kidneys. You see the kidney here? 32 weeks. What is the size of the kidney at 32 weeks? The kidney, the cerebellum, the clavicle, and the foot are about in millimeter the same size of the gestational age. So for 32 weeks, it should be about 32 millimeter. It's not very precise, but this is just a simple rule of thumb. So here we have kidney that 6 or 7 centimeters is too big. So we put this into omium, and we have no answer because we put too many criteria. So let's try macrosomia and ascites, nothing. Let's try ascites and nephromegaly. Oh, now we have one here that says fetal gigantism. Well, fetal gigantism is the same thing as macrosomia. So now we can change the terminology and click on this, and here we have the permanent syndrome. So you see how by switching one keyword for another one and trying again, you can get to the answer. I'm going to skip this one. So in the middle level, what you want to do is associate some small finding. Here we have a skin tag in front of the ear, and when you see a skin tag in front of the ear, think about golden heart syndrome. So if you have 3D reconstruction, this is a good time to do a 3D scan of the face to see the hemifacial macrosomy. Now, do not jump to conclusion. Here we have an overriding aorta, and I don't time to show you the whole thing, but so you see overriding aorta, you think tetralogy, but on the video clip there was no pulmonary artery. So this is pulmonary atresia with ventricular septal defect. This is another one that gives us a lot of trouble. This is a 35-week pregnancy. Femur is measuring 26 weeks, uterus is measuring 23 weeks. You see the baby has a lot of soft tissue, so it's not growth restricted. You see in the hand there's a single palmar crease here. In the other hand there's another single palmar crease. There's overlapping of the fifth finger over the forefinger, so the baby has clinodactyly. Kidney 23 and 29 millimeter, that is too small for the 5 weeks. There is ventricular megaly, 14 millimeter. There is a downturned fish mouth with a corner of the mouth lower than the middle of the mouth, and there's a large atrioventricular septal defect. So atrioventricular septal defect, short limbs, semen crease, hydrocephalus. What's diagnosis? Yeah, trisomy 21. I will be the most difficult. So we do the amniocentesis, we send a report, we send a result, and it comes back normal. So what should we do now? What we should have done from the onset is go to omium and put all this keyword together, and when you go into omium, here comes Smith-Amielli syndrome. So we should have taken a few more cc of amyloid fluid, asked for the metabolite of the cholesterol, and we would have the diagnosis. But I was so sure by looking at the atrioventricular septal defect and the short limbs and the semen crease and the ventricular megaly, I was sure this was baby had trisomy 21. So I didn't do the mental effort to go to omium, and I missed the diagnosis. Now, you know the proper vocabulary to search on the anomalies. I show you the body spur. And then at the advanced level, what you want to do is put together findings and recognize the most discriminative. So here we have a baby that has a cystic hygroma, it has some pleural effusion, it has a poorly coiled cord. What happened with the elbow here?
No, it's
The skin is tight. This is called joint webbing. This is a very unusual keyword. So that's the one you want to use. What's happening with the face? How about the mouth? Macroplasia, no set ears, retroverted ears, okay? So we put this into omium, and omium doesn't talk about fetal things, so this is not a good choice. So joint webbing here has 9, decreased field motion 7, we put them together, but omium doesn't work with fetuses, so that doesn't work. So what we need to do is something different, and then we're going to try now cystic hygroma and joint webbing. And when we do that, we get Noonan syndrome and Therigium-Colley syndrome. Now, Therigium-Colley is the word that the pediatrician are using. We use cystic hygroma, but the pediatrician are using Therigium-Colley. So we use now pterygium and joint webbing, and now we get the multiple pterygium, the Escobar variant, which is what this baby had. You see again, searching for some keyword and trying more and more. Now I do not omit findings even if they appear impossible. These are conjoined twins. Can you have boys that are conjoined? Yeah, of course. Can you have two girls that are conjoined? Yeah, most conjoined twins are girls. Can you have a girl and a boy that are conjoined? That's it. This is a boy, this is a girl. How is that possible? Because you had, from the original cell mass, you have a loss of a Y chromosome. This was a 46XY chromosome. It turned into heterozygotic conjoined twin. So once the line continues as 46XY, the boy, and the other cell line loses the Y chromosome, and now we have 45X0, the little Turner syndrome. So if you don't believe your ultrasound image, then you cannot get to the diagnosis. So you have to always search for rare and unusual cases. So to sum up, your most basic function is to sort fetuses between those that will have no problem at birth, and these can be delivered in a small hospital far away, doesn't matter. Those that will require intense scrutiny at birth, and those need to go to the big hospital where they can have pediatric cardiologists and they can have intensive care nursery. And those who will not survive, and there's no point in making a lot of effort to try to save those babies. And the exact diagnosis is really the icing on the case. This is what makes prenatal diagnosis such a fun specialty, because you can anticipate rare anomaly like that conjoined twin. Thank you very much. And also thank you very much for having me in Azerbaijan. It has been a great treat for me, and it's been thanks to the long amount of work